So the next talk by Dr. Fortin is the treatment of lupus and emergency in slow motion, and I'm going to give you an update on the new treatment coming for lupus.
So I'm back. I'm the last thing before lunch, so hopefully you'll excuse me. I'll try to make this as easy as possible. So this second talk, I have always a hard time comparing myself to cardiologists. I don't know about you. I mean, cardiologists are always, very popular when they're training as residents, and rheumatologists are usually low-key. Cardiologists also have a high level of immediate attention because often if you present with an acute coronary syndrome, this is an emergency and all of the emergency staff is around the patient and around you. So rheumatologists, not the same. I want to reverse that trend and I want to convince everyone that lupus is actually an emergency. So same conflicts. So the objectives for this talk is to discover how treating lupus is an emergency, maybe in slow motion, still an emergency, to review the principles of response in lupus and their impact in the study design, to review treatments available in lupus, and to know how these new treatments that are coming along. So I have this example, someone I came on, unfortunately, in the late part of his disease when I moved back to Quebec City, but an ex-manual worker, because he's been invalid now since 2005, married, father of two, and is now living in a nursing home for the past 2 years. We're now in 2014. In 1980, he presented with polyarthritis. In fact, when I see him, he already has Jacquard's deformity, and the part I put in red are actually damaged that have appeared over the years. He has severe hemolytic anemia on presentation, thrombocytopenia. He, in fact, had to receive a splenectomy because of resistant treatment. Pericarditis, dsDNA, anti-nuclear antibody, and he was initially treated with prednisone and hydroxychloroquine, and then methotrexate for years that were switched for azathioprine. But remember, he was diagnosed in 1980. Treatment options were not as wide as they are today, even though they're still limited today. 1995, he had the first deep vein thrombosis. He was treated with Coumadin for 6 to 12 months. He's always been antiphospholipid antibody negative, so Coumadin was stopped after that period of time. 2002, there's this mention in the chart on an echo that he has mild aortic insufficiency, but that doesn't seem to be followed up for a while. 2006, he comes in with purpura, and a biopsy shows leukocytoplastic vasculitis. He has a recurrence of his hemolytic anemia, and bang, he has a DVT again, and this time he's put on anticoagulation for life. Then starts the other side of the story often, the infectious complications. 2007, he has a severe pneumonia. It's diagnosed with nocardia, clearly related to immunosuppression. So his Imuran is stopped, and he's treated with antibiotics for 6 months, in which period of time he's not treated with immunosuppressive. So what happens? Well, his disease is back in 2007, and there he gets proteinuria, hematuria, and in fact he has a milder form, like we saw just now, of lupus nephritis, mesangial, and because other components of his disease, like the polyarthritis, had recurred as well, he's put back now on methotrexate. Unfortunately for him, the swing again of the pendulum is that in December 2008, he comes in after investigation for failure to thrive and low-grade fever and weight loss. He has lymph node. They initially thought he may have had lymphoma, but on one of those, they ended up biopsying mesenteric and duodenal lymph nodes, and it grew atypical mycobacteria, for which he had to be treated for 2 years with triple therapy and had immunosuppressor stopped again for this whole period of time. He had little things happening after that, like a spinocellular cancer of the skin. In 2010, he had a gastroenteritis and came in with septic shock. And finally, in 2012, this very benign aortic valve insufficiency that had occurred before now is full-blown Liebman-Sachs endocarditis of both the aortic and mitral valve, and he has to have replacements of both valves. In 2012, he's starting also to have other complications of his disease. He has a total knee replacement for avascular necrosis, and during his hospitalization, he has 3 CVAs, mostly in the occipital lobes, and he becomes blind, and it affects his memory, which ended up bringing him to be placed in a long-term care nursing home. In 2013, he starts having vascular complication in the periphery with gangrene of his third toe. And he's found at that time on investigation to have hyperviscosity, thrombocythemia, and a platelet count of more than 1,000. So following that, he's further investigated, and long and behold, this time he really has a non-Hodgkin lymphoma for which he's receiving Rituxan. Infectious complication ensues, and his lymphoma recurred, and he just passed away recently. So as a rheumatologist, when you inherit a patient like this in 2014, there's really very little room for you to do anything. This man is unfortunately mostly plagued with damage from his disease and all of the complication of his treatments, and we have to try to use it as a case to understand what could be done differently. So other complications that he accumulated, so not only did he have avascular necrosis of one knee, but both knees and both hips. He had osteoporotic fracture. He had bilateral neurosensorial deafness, probably from autoimmune nerve involvement. He had cataracts. He had 6 of the 11 ACR criteria over the years. He had a very high damage, and I'll come back to that in a moment. And he also had health habits that could maybe have been modified. He had never been advised that smoking maybe was a very bad thing for someone in lupus, not only just for someone in general, but that it's much worse in lupus. He was on fairly high doses of corticosteroids because he had had his other immunosuppressors stopped, and maybe there could have been some judgment made there that we should try to minimize exposure, but he's always been at least 10 milligrams a day. And then he had a lupus disease activity that was in periods of time, sometimes quite prolonged, suboptimally controlled because of his infectious complications and other reasons. So we want to discover how treating lupus is an emergency in slow motion. Well, I think that we've talked about this earlier, right? The take-home message was that there is still an unacceptable, at least 2.5 increased risk of mortality in lupus that we have to explain and adjust for. I want to go over this concept. So when we assess lupus internationally now, there's been consensus we should talk about 3 broad concepts when we look at each patient with lupus: disease activity, disease damage, and health status. So what is disease activity? It's a concept, right? It's been defined just to try to help understand lupus, and it's not like always applicable, but in our patients' disease activity, it's a concept that varies over time, and so this is a line of time. You could have optimal disease activity, like 100%, but it could at period of time become completely normal and to 0, so it's completely reversible. But damage is a different matter. Damage is really a stepwise function, and once you've accumulated damage, again conceptually, you can never go back to 0. And really damage is probably a function of activity over time, and it just goes up. And obviously, although we do want to treat this initial or this peak of flare of disease activity, we have to keep in our mind that we have to juggle that, and on the other side of the balance, what will it imply in terms of future damage, 5, 10, and 15 years? Because we've also seen that a lot of the events occur 7, 10, 15 years after the diagnosis. So this is our gentleman with his disease activity over time, but really he has accumulated damage. And in fact, the last few years of his life, his disease activity was not much of a problem, but he had accumulated so much damage that he was non-functional, had terrible quality of life, and definitively had premature death. From, people would say he's died from lymphoma, but I would argue that he died probably more from his accumulative problem with lupus. So, concept that covers all dimensions of health. So we said activity, damage. The third dimension is health status. So it's been used mostly with a general measure of health status called the short form 36, because this short form 36 covers 8 dimensions of health. One of them is vitality. And it's important in our patients because fatigue is always a constant problem in our patients with lupus that is captured by this vitality scale. And then it can be scored in summary scales of physical component scale or mental component summary scale. And these are normalized to 50. So if you have an average population survey of an SF36, the scale of physical component is 50. So you can compare your group of patients with disease to a normal control. So if anything is below 48 as an average, it's considered as clinically important difference. So anything below that. So we'll see in some of the work that's been done, and we've replicated this in Canada in at least 2 other cohorts in Toronto and in McGill, and we find the same thing as Fred Wolf in his population. We find very severe impact of physical component scale. I said 48 is what's clinically relevant, and I think below that is significant. I can tell you 36 is very low. Now, we have these young women that look well, actually, when they come into your clinic, but that's what they report. And if you compare this is comparable to the quality of life you would have in end-stage COPD or in end-stage cardiac disease, which are usually populations that are in their 60s or 70s, but our women are 40, right? And their mental component scale is also affected, but not so as much as the physical component scale. In my mind, is this the remarkable ability of human being to adapt. But so my case is that the treatment of an acute flare of lupus is an emergency. The goal is to induce a clinical and preferably concomitant immunological remission, because you do see patients that will have a clinical remission that remains with abnormal C3, C4, dsDNA. So you want ideally to have both, and that the decision taken must take into consideration the need to control the present acute inflammation, that blue line, the activity, but also to prevent the long-term complications. And one of the things I didn't describe is that in the damage scales, it captures not only damage that's due to inflammation from your lupus, but it will also capture complications of your treatment. So if you had avascular necrosis that is attributable to your steroids, this is still a damage that counts for this scale. So you have to balance those. And I don't want to go over this algorithm, because this is actually from our colleagues in cardiology. But the point is here that they've sorted out a very defined algorithm that if someone presents with symptoms suggestive of an acute coronary syndrome in the emergency room, you will have all of a guided pathway that within 24 hours, usually within minutes to hours, you will have to have done some of those and make a decision whether you need to do some either antithrombotic or intervention therapy to revert the ischemia. So why do they do that? Well, and what is the equivalent in lupus? Frankly, I don't think we have an equivalent in lupus, and we need it. But why do they do that? So if we have a timeline here, and you have an acute coronary syndrome and patients presenting, and you have a scale over 24 hours here, what happens? Well, you look at what I will compare as activity of your acute coronary syndrome and damage to your myocardium. So the diagnosis is made. Okay, someone is in emergency. Okay, let's start the clock. And we are good. We're starting treatment very quickly. We're decreasing the ischemia, and hopefully there's no damage to your myocardium, right? That's what the cardiologist wants. What if you were to delay a little bit your treatment or your intervention? And presumably the problem is you have a risk of having a little bit of damage to your myocardium, but still, hopefully, within a range that it's not going to affect the quality of life long-term of your patients. But what if you were to delay it to 24 hours or more, which is really the guidelines that you should not do that? Well, obviously, it's been demonstrated that the risk is that you will have significant damage to your myocardium and much more difficulty with your patient long-term. So I would just suggest, let's change this. Let's think of your scale as a scale that is not over hours here, but maybe over months. And let's think of how you could prevent that difference from happening, because this is a difference for your patient that's very significant, from no damage to left ventricular heart function that is very low. And let's replace your acute coronary syndrome with lupus. And I think we have to start thinking that way. I've seen a lot of complacency about patients presenting with some lupus manifestation, and for some reason, the internists or the primary care or the patients, the physicians they've been seeing have been hesitant in really starting interventions because of the risk of toxicity. But we often lose in the equation that delta here. That's important. So this is a leeway to go to what are the principles of response of lupus and their impact in study design. So we've reviewed those just now. Activity, damage, and health status are important. So why is there a need to improve outcome in lupus? Maybe we could say, our lupus patients are doing so well, we don't really need to worry to change things. But I think we just reviewed that the morbidity related to long-term complication of this disease is still unacceptable. I think the case presentation at the beginning that I presented showed you that damage is really a threat to our patients. Damage could be cardiovascular, osteoporosis, malignancy, In children, there are also some specific damage to them, stretch marks, growth retardation, and amenorrhea. Quality of life is comparable to that of older patients. I've just shown you those results with the SF36 as an example. And we've seen the data on mortality and mortality being still unacceptable. So there is a need to rethink what we do with our treatment in lupus. There's immediate challenges of lupus management. So, when a patient comes in, they're often overwhelmed by the number of tests we ask in order to establish the diagnosis and the extent of their flare. We have to provide emotional support, which often we don't think of or we're not equipped of doing. Certainly in Canada, we were discussing, we don't have a social worker in our unit. We don't have anything to help the patient and the family, because the family is going to be important in how the patient will decide whether they're going to take their drugs or whether they're going to follow up with the recommendation. We need to communicate effectively with the person, the family, and discuss the treatment plan and the choice of treatment and why. We need to try to justify it and explain to them that we are aiming to that control of the disease activity, bringing the blue line down to 0 without having any red line. So it is a balance, we've said, the fine line of lupus management. More treatment is good because we want to decrease that blue line. We want to control the inflammation. We want less flares. We want overall less damage for our patients. So steroids are an example of what's good. We've seen that in lupus nephritis, they're recommended for most of the acute, severe presentation. But you could also say more treatment is bad because you could have more chance of side effects, infection, osteoporosis, cardiovascular disease, and damage from drug side effects such as steroids. So there is this immediate and this long-term tension or challenge in lupus management. So in immediate, what you want to do is control the present activity, and so you will use a drug with the best risk-benefit profile, and you would consider possibly other interventions to control. You want to prevent damage, so in your choice of drugs, you're going to want to have damage from inflammation or from complication of treatment considered. So if you have someone presenting and you use steroids, well, you want to use the minimal dose of steroids needed so you don't increase their risk too much of having, for example, avascular necrosis, but you still have to use the right dose. And then you want to ultimately induce a remission when someone presents with severe or with activity. Then you have the long-term parameters of this equation, and so you are someone now in remission, so you want to maintain that remission the longer we can. So we want to best use the remitting drug. When is it best to stop? We've just discussed this, and I don't have a magic answer, right? But this is a consideration. We want to prevent the complications of the disease and the complication of its treatment. So we want to also make sure that we provide a good quality of life. That's often we tend to think of as less important as activity and damage, but it's equally important, certainly from the patient's perspective. So how does this translate into doing trials in lupus and trying to get answers and recommendations in lupus? Well, if we think of induction, this is really the issue of trying to control the active disease. You want to induce a remission, and the way it's been done traditionally is either by taking a group of patients with lupus, doing the intervention, and measuring the group average change in disease activity. And these trials have not been very successful. So then people have started thinking, well, maybe we look at the number of individual response. Instead of looking at the group average, we'll just say this one responds, this one doesn't respond. And then the other thing would be to look at adverse events. And I'll come back to the number of individual response in a moment. For the maintenance trials, when someone is in remission, trying to answer how long you want to continue the medication and which medication you use. So here now, what you want is not necessarily controlling disease activity, but keeping it at the lowest or hopefully in remission for the longest period of time. So you want to maintain that remission. And so you would look at, sorry, I've done something wrong here. Just there. So you would look at the outcomes as the number of flares. You want to have either less flares in terms of numbers of flares, or you could look at it differently. You could say, I want the longer time possible until a flare comes, because we know these are remitting and flaring diseases. The second thing is you may want to look as an outcome on the maintenance period of time, how quickly you were able to stop your steroid, or at least how low a dose of steroids you've been able to achieve, so the sparing effect. You're going to look at damage accumulation and trying not to have any damage, and the number of adverse events. So I'm coming back to the primary question about having individual responders. And this is really one of the things that has been key in progressing in having a drug approved by the FDA and Health Canada, for example, in lupus, which is the belimumab trials. The main difference between that trials and the trials that had been done before is that they define this SLE responder index. And what they've done is they basically combine some of those concepts. What they said is that for me to think that the patient has responded to the medication, I will first prove that their disease activity decreased. So they will look at one measure of disease activity, here the Selena-Slide, and they've decided that if a patient has decreased their disease activity at least 4 points or more, they've had some objective measure of decrease in disease activity. But because lupus can vary between each other, they wanted to also make sure that even though the overall decrease in disease activity, there was no increase or active disease in one specific field. For example, overall, you may have people improving with their hemolytic anemia and their arthritis, but they're appearing with serositis or something, or a rash. So they wanted to make sure that looking at the subscales of the BALAG, there would be no new increases in disease activity. Okay? And then the last thing is they wanted a validation that was external to these two measures by one of the assessors in the trial, so one of the physicians. So in order to be considered a responder, you'd have to have 3 criteria met, which meant an improvement in overall disease activity on a scale like the Selena-Slide, no worsening of disease activity in one of the subscales of the BALAG, and an improvement validated by an external observer that was a physician. And this is how they basically used the collective information that was learned from the previous trials. So I just wanted to talk about when you're going to read your next paper on a report of a trial in lupus to understand those issues. So now we review the treatments that are available to us. And this is a little bit of a kitchen list, so spare me, hopefully, allow me to present it, but I always start with saying we have to do some routine checks. Again, patients are often not as well, I don't know here in Kuwait, but in Canada, they're not as well taken care of by their primary care physicians when they have one, because they're specialized patients and they are seen more often by their rheumatologists, and patients tell us that it's easier to see you than to see my family care. But there are some principles that we should always follow before we even think of medication. So some of them is to discuss with them the photosensitivity. We had a good talk on cutaneous lupus and the importance of protecting from the sun. This is something we repeat to them every time they come. They often will tell me in the office when they enter my office, yes, doctor, I've been good with my sun protection, because I always keep telling them. Think of calcium, vitamin D. Sometimes if there's a need for bisphosphonates just because of the risk of osteoporosis. Maybe think of bone mineral densities and when they're needed. Ophthalmology consultation, if there are on Plaquenil, this is very important, and they often don't go for that. Flu shots, pneumonia vaccine, and one of the things that often is getting forgotten is pap smears in these young women, and they are possibly at higher risk for papillomavirus. And family planning, we discuss it up front because often they won't discuss it so that you don't tell them any restrictions, and it is important. And this is something Dr. Bargman has shown me to do, to always not let them go without having that discussion. So what are the changes? Lifestyle, I also always mention, like this gentleman that we saw at the beginning of this presentation who was smoking for 20 years. There should have been really at least a discussion with him, which had never taken place when I saw him, which was too late by the time I saw him. But lifestyle, exercise is always good if you can continue to exercise. So the sunscreen we've mentioned. And then what are the choice we have? Well, we have the antimalarials, we have the anti-inflammatories, the steroids, the immunosuppressants, and now we're entering into the era of the biologics. So antimalarials, they traditionally have been always thought to be very good for skin, joints, and serositis, and maybe fatigue. But what we've really learned in the last maybe 10 to 20 years now is that they're not only good for that, they're also very good at preventing flares, and they're very good now, they've been demonstrated as improving the outcome, so that you have less damage accumulation in patients that have been on antimalarials for a long period of time versus those who haven't. So few side effects, We know those side effects. The one of them that is mostly of concern to most of our patients is the vision problem. Now, they do increase skin coloration over time. There's a possibility. And some people have quite significant GI side effects, and there's a very rare myopathy that's associated with them. But the eye problem is probably what comes out the most. The American Association of Ophthalmologists have made some recommendation that there should be a visual examination in the first year after starting the treatment. And this should include a retinal examination of the dilated pupil and some visual fields testing. And if the patient is at low risk, they don't have macular disease degeneration, they're not older than 65, and they haven't been on the drug for more than 5 years, they could be seen 5 years later. If they're at high risk, including those that have been taking the drug for 5 years or more, they should have an annual examination. The other group is those with obesity, because the antimalarials can accumulate in the fat and can actually increase your serum level and cause toxicity. Steroids, I have only a few slides on that because there's so much you can say on steroids, you could spend an hour. But for the most severe lupus manifestation, but they're really still what is the effect of water over fire, right? They're very good at having a rapid effect, and then their dose can be gradually lowered, and the chronic use increases the side effects, obviously. So we try to limit their long-term use. What are the short-term side effects? You all know that: weight gain, mood changes, sleep problems, acne, stomach upset, high blood sugar, high blood pressure, menstrual irregularities. Acne is often one of the big issues in our younger women. There could be also longer-term side effects: osteoporosis, glaucoma, cataracts, avascular necrosis, striae, and increased lipid profiles. The immunosuppressants, so we've talked about Imuran or azathioprine, methotrexate, the mycophenolates, cyclophosphamide, or cyclosporin or tacrolimus. So azathioprine, it interferes with purine synthesis, so with the DNA synthesis, used to treat pleuritis, pericarditis, nephritis, and arthritis. The side effects could include all of those: low blood counts, increased risk of infection, inflammation of the liver, or there might be this mild increased risk of cancer. We need to check regularly the blood for at least for complete blood count, liver function test, and there could be interactions with allopurinol, so we have to be careful of that. And some places use TPMT enzyme testing, but it's still to be proven to be really that cost effective. The methotrexate, everyone knows here quite well, and maybe I won't go over all of that. The principle is that these drugs all require monitoring, and they're basically having an effect on rapidly replicating cells. So the white blood cells being rapidly replicating cells, we're decreasing their effect. The mycophenolates, so mycophenolate mofetil is the prodrug for mycophenolic acid. It's developed for it was developed for prevention of transplant rejections. We're borrowing from that field in lupus. It's used to treat nephritis mostly, and it may have a role in treating other manifestations like arthritis or serositis. The side effects include, again, low blood counts, nausea, and diarrhea, and we also need monitoring. Cyclophosphamide, I think we've talked about it quite a bit. There's still indications, certainly in severe lupus nephritis and CNS lupus. And the cyclosporin and tacrolimus, it's a calcineurin inhibitor, and it's not as much used as an immunosuppressor anymore, and I think its only indication for me anyway has been recently in having an effect on proteinuria in severe proteinuric patients that we cannot control completely. So biologic agents, the only one that's been approved is belimumab, but there has been experience with rituximab or even abatacept. For belimumab, what we are looking at is that basically blocking the effect of this cytokine, the B lymphocyte stimulating factor. What it does is basically on your B cells, you do have these BLyS receptors. And if you have an interaction between the BLyS and the receptor, it will prevent apoptosis of those B cells. So it would prevent self-death of these cells, and it will prolong the presence of these autoantibody producing B cells in your system. And basically, there is in lupus a documentation that there is an overproduction of BLyS, and the antibody is really blocking the peripheral BLyS cytokine, doesn't interact with the B cell receptors, but in blocking the BLyS, it prevents from having too many of those interactions, and so it will basically decrease the survival of B cells, right? That's how it works. Rituximab, so we've talked about it. It's a chimeric monoclonal antibody against the protein CD20, which is a marker on surface of B cells, so it actually kills B cells. It's approved in the treatment of B cell non-Hodgkin lymphoma and in RA. The trials we've talked about in lupus have failed, probably because of, possibly because of trial design, so the use of concomitant steroids, the choice of outcome measure. And the reason why we think it may be methodologic is that they had the primary outcome, but they had like 6 other secondary outcomes, and none of them showed any evidence of a signal. However, like we said, several case series are suggesting that there could be still an effect and a use for rituximab in lupus. So, last part of this before your lunch is to know how new treatments for lupus are becoming available for trials. I've borrowed this slide here from a paper by Cifuentes because I thought it really covered all of the different possible targets in lupus. So we've talked about apoptosis generating nucleic acids that could become target for autoantibodies and become the antigen for that. So autoantibody synthesis and, the creation of immune complexes. Immune complexes are taken by antigen-presenting cells. They can then interact with, through secretion of interferon alpha and the interferon alpha pathway to stimulate the B and T cell reaction. And these are all possible targets in future development of drugs in lupus. So what are they? Well, the interferon alpha is only one of the target that's been of interest. So blocking the interferon alpha. And the other possibility would be through toll-like receptor inhibition. So there are in development monoclonal antibodies that are interferon alpha blockers. There are the concept of vaccines for interferon alpha that are developed, and then blocking specifically the TLR7 or 9. And it's interesting, like all drugs coming back, that in fact for a long time we weren't sure how hydroxychloroquine worked, but there seems to be definitively an impact on TLR7 and 9. There are other compounds specifically targeting these receptors. There could be also an approach where you would block cytokines that are promoting autoimmunity, so anti-IL-6. Some drugs like tocilizumab have been considered for that. And then anti-interferon gamma. So these are where the interferon pathway would have a benefit, and the TLR receptors here. The other ones would be new roles for immunosuppressors, so rethinking MMF, tacrolimus, maybe sirolimus. B-cell antigen agents, so the B lymphocyte inhibition. We've talked about the anti-BLyS. Eli Lilly was developing a drug that could have also have the additional advantage of blocking the receptor, not only the circulating BLyS, but their phase 3 trials was a late phase 2 trial, was negative, and they stopped the development of that drug. But there are others that are being considered. And then there could be stem cell transplantation. There has been some studies suggesting that it works in lupus. The problem is toxicity, trying to balance that. So we see here where the BLyS would be the target, where the other B cell receptors are. And finally, immunomodulatory agents that could be developed. So we don't need to go over them. So today I tried to show you why I think lupus is an emergency in slow motion. We reviewed some of the principle of response in lupus and the impact in study design. We talked about treatments that are available and how new developments are happening in lupus. So thank you.